campus. There's the Kids Escaping Drugs arm, and then there's the treatment arm, which is Renaissance Addiction Services. So Kids Escaping Drugs is a community education, early intervention program. They provide a variety of services. We do what's called face-to-face in the workplace, and that's where the team goes in and speaks with folks in their workplace about current drug trends and things that are going on in the community regarding drugs, treatment, prevention, education, things like that. We also have a program that's an early intervention program, and that is free of charge. We're in about 140 school districts, and so a concerned teacher, a concerned parent calls and says, I was putting my kid's laundry away and I found some paraphernalia. So they come in for an early intervention, which is free, confidential, very non-threatening. We pull a few of our upper level kids from the campus to come on over here. And so first the interventionists will meet with the parent or guardian, and the kids will meet with the kid, and then they switch. And based on that interaction, we make a recommendation. And typically it's one of three things. Your kid's really in early experimentation, or we suggest home drug testing and maybe some counseling. The second outcome is typically, oh, it looks like your kid's kind of getting deep into drug use. We suggest an outpatient assessment. And then periodically we get a kid who is so far involved with drugs and or alcohol that we immediately do an assessment for the campus. So again, it's community education and early intervention. It's not a prevention program. It's very different. Then the campus itself is, right now, it's 62 beds, though where one building is being prepared slowly, hopefully, to become a community residence. So what we have is we have Stepping Stones, which is the building right there, which houses 18 girls, ages 12 to 20. And then we have Renaissance House, which is the larger building, which is 30 beds for boys, ages 12 to 20. We have a large gym, which is the building that you see as soon as you come in. Length of stay here ranges from about 3 to 6 months, and we do all sorts of things. We do a lot of fun activities. We go to a lot of Sabres games, a lot of Bills games, particularly kind of to teach the kids how to have fun without drugs and alcohol. We do treat those individuals with
joining the meeting.
Hello. We do treat those folks with co-occurring disorders. We have a psychiatric nurse practitioner, a licensed mental health counselor. We have a social worker. We have an art therapist. We do lots of evidence-based practice. We are trauma-informed. We continue to work towards being a trauma-informed culture. We do EMDR, we do seeking safety, we do DBT, we do lots of evidence-based practices. And then we transition the kids out into the community, and hopefully many of them remain active alumni and participate in other kinds of activities. So that's really a quick and dirty snapshot of what we do. I'm certainly available after if anybody needs more information, but I welcome you all. Does anybody have any questions? Okay, thank you. You're welcome.
Thank you, Boogie and Evan. Now I will ask people in the room to please introduce yourselves. So I'm Rachel Laster. I'm the Community Outreach Coordinator for Millennium Collaborative Care. Next we have
Mia Burns. I'm from the Buffalo Federation of Neighborhood Centers.
I'm Lisa Casper. I'm from the nursing here at Buffalo Niagara.
I'm Ray Gano from
Can people
Evergreen Health.
please speak up? Thank you. Can you speak up, please?
Ray Gano from Evergreen Health.
Al Hammonds, Millennium.
Luann Brown, Buffalo Prenatal Perinatal Network.
Courtney McDermott, Millennium.
Chris Spicer, Planned Parenthood. Karen Gallardo, I'm the Maternal Infant Health Initiative Coordinator at Niagara Falls Memorial.
I'm Sandy McDougall, I'm from Millennium Collaborative Care.
I'm Ann Battaglia with Healthy Community Alliance.
Vicki Kaminsky, and I'll be working for Western New York Integrated Care Collaborative.
Ken Jenowik, Mayor County Office for the Aging and Board President for the Western New York Integrated Care Collaborative.
Eric DeSoy from Empower from Niagara County.
I'm Cheryl Mitz, I work for New York State Office of Children and Family Services.
Monica Morbido from New York Star.
Ricardo Rivera, Executive Director, Buffalo Federation of Needy Centers. Rafiq Salim, Mental Health Peer Connection, Western New York Independent Living.
Ira Katzenstein, Cataracts in Wyoming County's Head Start.
Mary Carroll, Erie County Council for the Prevention of Alcohol and Substance Abuse.
Star Wheeler, Native American Community Services.
Carrie Clare from North Point Council, Lander County.
Marvin Gordon, North Point Council.
Rita Hubbard Robinson, Millennium.
Ebony Patterson, White Millennium.
Michelle Mercer from Millennium.
Kim Packey from Millennium.
And if you find individuals on the phone, could you, we'll try to make this as non-bumping to each other as possible. But if you could please say who you are, we'd like to see who's calling in.
Denise Wilson, Erie Niagara AHEC.
David Moss, Prevention Focus.
Jennifer Sullivan, American Lung Association. Amanda Delona, Indiana Jackson Living. Amanda Nobrega, Alzheimer's Association of Western New York. Elias Bacone, Buffalo Psychiatric Center.
Stuart Harper, Buffalo City Mission.
Robin Kruger, Community Mission.
Francis Patterson, Western New York Children's Psychiatric Center.
Sue Bissonette, Casablanca Recovery System.
Carrie Whitwood, Artist Merchant.
Mindy Cervoni from Community Services.
Michael Meeting United Way of Buffalo, Erie County. Jerry Bartone, Community Concern, West New York.
Okay, well, thank you so much. And we'll now proceed with the rest of our meeting. I'd like to welcome Sandy McDougall.
You may interview first.
Sorry, we're actually going to do our minute review first. So if you did pick up a set of minutes from our last previous meeting. Yes, I don't have it. Does anyone, please, they were emailed out on a while ago, but if you have any changes you would like to suggest, I would welcome it at this time.
They were mailed out the U.S. Postal Mail?
No. Emailed.
Email? Oh,
Yes.
okay.
And it would only have been to our previous CBO task force members. So if you're wondering why you didn't get them previously, that would be the reason. But I have your contact information now, so you'll get this set of minutes. And for the individuals on the phone, we weren't able to really get that roll call down as nicely as we would have liked. So if you could potentially just shoot me an email saying that you were on the phone call, I'd appreciate that. Do I hear any changes or suggestions, alterations? No.
Not a motion to accept.
I would like it. I entertain a motion to accept.
Make a motion.
Second.
Who made it? Look at Ellen and Ricardo. Thank you. Okay, probably second it. I'll call for the vote. Ayes. Aye. Carried. So thank you for that. And now I'll present Sandy McDougall. She will be giving us our presentation today on value-based payment 101.
And actually, we have a couple of people that are going to be jumping in. anywhere that I'm just moving you guys over so you're closer to me, the telephone. And I know we have some various expertise in the room that have had experience with value-based payment at different levels. So I'm Sandy McDougall, I'm the project manager for community engagement as well as the maternal child health projects. And in addition, we have Rita Hubbard-Robertson back here who's got a lot of expertise in the community and what a lot of you do, as well as Michelle Mercer in the back, who's going to be going through some of the things of what Millennium can do to help. And I'd like to also point out Luann Brown here from Buffalo Prenatal Perinatal. She's been through a lot of the state's education and has been doing a lot of alignment work as she goes through this process as well. So she's got a little bit of level of expertise too to help us out with this. So this is really about bringing everybody together to really, as a team, we've got to start looking at how do we start positioning ourselves, how do we get ourselves there. So what we're going to go through today is just a very basic, what is value-based payment, what does that mean? We're going to take a look at the roadmap that the state has put out, as well as CBO tiers is going to be real important to understand. There's a couple of these things like tiers I'm going to repeat a couple times just because it's really important information. We're going to talk a little bit about value proposition, but that's something that in a future education we might be able to do more on. We're going to talk about social determinants of health, which is what your guys' business is. Implementation considerations specific to being a CBO, as well as our role as Millennium. There is a question and answer discussion at the end, but if anybody has a burning question, please feel free. I would love this to be discussion. And make sure questions are answered as we go, because sometimes they tend to be forgotten. So with that, are you moving the slides? I can. Okay, so what we're going to start with really is what is value-based payment? It's a big word, and a lot of changes occurring behind it. But if you think about it, it really is a movement in the system, looking at how things are paid for. So typically in healthcare right now, people go for a visit, and they get paid, each of the practices, by what they call fee for service. So the more people you see, the more tests that are done, that's how you get paid. Okay? Going to a value-based payment system really is looking at moving away from value to quality. So it's really what are the outcomes. So if you have a population, how do you move those outcomes? How do you know those outcomes are being met? And it really is starting to move us from thinking about just treatment to also prevention, when you think about it overall. So New York State has been working on this roadmap for a while. They actually started this work back in 2011. When you think about it, the governor recognized that we spend an awful lot of money in Medicaid. And I'm going to be honest, as a country, we spend more money in healthcare than a lot of our partners, or I shouldn't say partners, other countries, even third world countries, sometimes have better outcomes than we do and are spending a lot less money. So it's really something we need to start looking at. And as all you know, the budget is getting harder and harder to beat in the process. I think there's a ton of things that can be done overall, and we need to start looking at it. And it's not necessarily, I mean, you'll often hear cuts. It's not really cuts as much as it's really looking at how do we right size? How do we have appropriate care going on? How do we have appropriate payment going on? And that has moved across the state in various parts. And one of the things that has been most recent is waivers. Anybody familiar with waivers? Yeah, you have quite a few. So waivers is a way to start looking at the system and saying, okay, we need to move the system and change how you're getting paid and move it to a more risk-based model. When you do that, often you can't just stop getting payment and wait and still do business. So waivers was a way to have that period in the middle where some of the money that was already coming through healthcare and providers could continue to come while they're moving themselves to where they need to be. And New York State, in its wisdom, in the end, just recently published the roadmap for value-based payment. So really, how do you get there? The roadmap goes through, it's a 42-page document. If anybody'd like to read it, I'm including the links. It includes the CBOs, but it also goes through providers, it goes through hospital-based, it goes through all of the different providers and how they need to start partnering to get there. So first thing I'm going to take you through through is levels of risk. And these next two slides is just kind of level setting a little bit in the fact that you need to understand the system and how they're defining everybody. So levels of risk is really the provider side. So if you're a provider of clinical care, you will follow this in some way. And I should say provider in clinical care as well as anybody who's providing services that can be billed through Medicaid. So level 0 just means you've had no risk, you've been paid fee for service. That's our traditional history. Okay? Level 1, you start to share in some risk. Okay? If you'll get your fee for service, and if you make a certain outcome and achieve it, you can get an incentive payment. Okay? So if it's achieved, you get it, but you're not actually losing anything. When you get to level 2 and 3 is when you start looking at the risk on both sides. So level 3, you might still have some fee for service, but in the outcome, if you make the outcome, you can get money, but if you don't make the money, you can lose money. Or if you don't make the outcome, you can lose it. And level 3, you're really taking all of that risk on, up and down. So the state actually has a goal that across New York State, 80% of providers of care will be moving to level 2 and 3 by 2020. When you look at New York State currently, we have about 30-35% of providers that are already achieving 2 to 3, level 2 to 3. So we have a movement, and I'm going to be honest, majority of that is in upstate, not in Western New York. So there's some movement going on there. And I'm going through this on the provider side because you need to understand where they're coming from when you start to partner as a CBO. So the next one we're going to look at is tiers. And this is your organization. As a community-based organization, you've got to start looking at what tier you follow. Okay? So tier 1, and I'm going to start everybody's nonprofit in this. The next question you're going to ask is, do you have the ability to bill Medicaid in any way? So tier 1 is non-Medicaid billing, is not billing through Medicaid whatsoever. Tier 2, and your social, your community-based social and human service organization. When you get to tier 2, you're still nonprofit. You can bill Medicaid. It may not be for all your programs, but you do have the ability to bill through Medicaid. And there's some non-clinical services going on there. Tier 3, nonprofit, Medicaid billing, and you have clinical support services provided. Please go ahead.
Did they define non-clinical versus clinical? For instance, our residential services, a lot of restorative services, we bill Medicaid directly for those restorative services. And care coordination,
right.
Pretty much the same.
So your care coordination or case management type stuff going on actually falls in tier 2.
2.
Okay? But if you have any medical services going on, you're actually providing medical level services, that's where you get into tier 3. Does that make sense?
Yeah. It's just like, in terms of help with medication assistance and that kind of stuff, I didn't know whether that would fall into tier 2 or tier 3.
If you're assisting, so you're looking at helping them with things like adherence, you're not actually prescribing, right?
No, we're not prescribing,
So
we're
at
just
that point,
making
you're
sure they
tier 2.
take their meds. So that still leaves us in tier 2.
It's still tier 2. Okay? And the state is looking at these levels. When we talked about that roadmap that just came out, they have made a promise that every year they will take a look at this because this is a learning process that needs to be evaluated and updated according to what the needs are when you look at it. So does that kind of make sense for the tiers for people? The other thing is we put a little pie chart down there just to tell you what that is. Many of you filled out recently a survey for us, starting to ask some of these questions so that we could start figuring out who falls in each of the tiers. And this is going to give you an idea from the people that answered the survey. There's about 70 organizations that did. You can actually see majority of the partnering at this point is tier 1 providers. One of the other things to remember when you're looking at tiers, many of our organizations have multiple parts to them. So you may be a provider or somebody who's doing services that can bill, and then you have some programs that can't. It's a tier level according to your organization as a whole. New York State did that on purpose because they really wanted to give the ability for those tier 1 providers who have never been in the system or been able to bill, typically been through grants, philanthropy, and that's all of their funding. You know all the programs, they get a grant. If the grant goes away and they can't find the next funding source, they end up closing because that's where they are. And they deliver a lot of really good services. So the state really has started to look at who they are. And I'm going to be honest, in their wisdom, the biggest thing you're going to see is they're recognizing from New York State that social determinants of health is a huge component of this. You know, think about it. If I can't get food, am I going to be going to my provider? Am I going to be filling my medications? You know, there are things within our community that need to be addressed to help people move to the point where they can have better health. And those social determinants are a huge part of that. And the state, and I believe it's New York State, is the only one I've seen, because I've been looking across the different programs that I see. I haven't found any other state that has included social determinants of health and what they're rolling forward. So this is the roadmap language. We're going to go through this a little bit, but I wanted to kind of walk you through a little bit, and you're going to now understand why I brought in the levels and the tiers, because this is the language that goes into the requirements. So New York State really is looking at the fact that all value-based payment, sorry, I keep using the wrong term sometimes because I came from when VBP was purchasing versus payment. So every so often I make that slip, and I'll apologize right up front for it. But all level 2 and 3 providers are going to have to address at least one social determinant of health. It's a requirement. It's a mandate. It's not something that's optional, or you will not fit the requirements for New York State under value-based payment. The other one we're going to really go on is the flexibility of really selecting and looking what social determinants of health actually hit. And then the fact that every one of those level 2 and 3 providers are going to have to include at least one tier 1 community-based organization within their plan. This document goes in place in January, but I will warn you, not all the providers to level 2 and 3 yet. They still have a little bit of time to get there. So this is a perfect time to start positioning and really thinking about what that road looks like.
How long do we have?
Well, the providers have another 2 years. So by 2020, 80% have to be up to level 2 or 3. So you're going to see across the next couple of years, multiple different providers moving at different speeds. Go ahead.
So, a question that I have is, if you've got people who aren't participating, does it necessarily creating their own, deals with insurance companies, if you will, their own value-based payments? They might still call it purchasing. Is this something that the state is going to mandate to insurance payers or to managed care plans?
So all of the funding actually goes through the managed care organization, and then the managed care organization is being held to those requirements.
Okay.
So then they're going to have to do that underneath them.
Okay.
You're going to see a little bit more when we talk about contracting.
Gotcha.
Can you restate the question for the phone, the people on the phone? Please.
I forgot the question already.
But my question was essentially, is New York State going to make all value-based payment programs adhere to these requirements? So that's what I was getting at anyway.
Yeah, and ultimately what we're saying is all of those contracts and stuff will be going through the managed care organization. Anybody who's not familiar with that term, we're talking about the Independent Health, Care, Fidelis, the Blues, you can go on with that list. But those are all our managed care organizations, and that's who the state is going to be holding to that. Please.
We meet with the managed care organizations monthly, and we've been asking them if they're prepared and are thinking about this very topic, and not one of them has told us yet that it's even on their radar. It is a mandate, as Sandy mentioned. They will be having to think about it, but they're not there yet.
So that tells me that they'll be looking very suddenly for anyone who's ready.
That's right.
right?
That's right. That's right.
Yes.
Yes, though.
And that's why we have the training. That's why
Right.
we're here.
Mhm. So when you start thinking about implementation for standards for social determinants of health, it's really starting to think about that intervention. And there's a wide range of definition from New York State on interventions and how that can occur. So the first thing you need to do is just remember, everyone's going to have to be partnering and have to be putting in at least one social determinant of health. And that's huge, because that sets the road for us as a community. Next one. And the fact that there's some rewards behind that, and this is where they kind of talk about the managed care organizations. So this money will go through the managed care, and then they will be held responsible. So you guys are ahead of me on my slides, look at that. So social determinants of health, so I want to spend a little bit of time, because we all have our picture of where we're working and what we're doing. The state, I'm going to be honest, I'm sure everybody who's working on social determinants can make it fit in any one of these pockets. So when you look at it, there's economic stability, things like poverty, things like housing security, food security, you can go on with those lists. Neighborhood and environment. Think about it, is there affordable housing? What is the environment like? Think about things like lead. If every house had lead in it, where would we be? And how does that affect health? Access to healthy foods, crime, violence, education. That's a huge component that's been recognized. I'm sure you've already seen where the governor is already giving out scholarships and stuff to help people for higher education. There's a lot of programs also looking at lower or elementary and high school education as well. And how can we improve that? Because if people start increasing their education level, they're going to be ready for the job world, they're going to be ready for, and you're going to start moving them from the situation that they may or may not be in and improving that. Did I say that the right way, I hope? Social and community context, really looking at social cohesion. How many times are people socially isolated? Ellen just talked about addictions and how they become socially isolated. Think about the fact that she said you got to teach them how to have fun. That's a huge piece when you think about it. There's civic participation, also looking at our incarceration rates and what's happening when they come back out. How do they get back into the community? All of those. And then there's health and healthcare. And that's a big one to think about, because as you start thinking about your social determinant health, you want to think about how it starts affecting in healthcare. So if I can do certain things, are they showing up in the emergency room? Are they showing up for inpatient admissions that could be avoidable? So those are the things we've got to start thinking when we think about outcomes and the things that we're doing and how does it impact in the healthcare world. And you guys have been hearing us talk about this term some, medical neighborhood. I love this because it's really starting to recognize the fact that the community is part of that. So typically when you think about healthcare, the first thing everybody thinks about is the big hospital system, going to my doctor, all of those pieces. But if you look at the medical neighborhood and all the pieces that we need to actually move the outcomes, you have to include all of these parts, including the community. And this talks about how there's flexibility across those. So as you start to look at different providers and where they are, what social determinant of health might be the priority may differ. So I think about the hospital system. I think about the fact that sometimes we had somebody who was homeless and we couldn't discharge them anywhere, and they sat in the hospital for long periods of time just because we didn't have a safe place to put them. You know, and when you're in the hospital, it's not always the best healthy place to be, to just sit and wait for housing. So there's lots of different things like that going on and how we can help and start thinking outside that box. Get that to play. Do you think it's started? Yep.
God's Love We Deliver is the leading provider of medically tailored meals in New York City's metropolitan area. What we do is we cook and home deliver meals that are individually tailored for people who are so sick that they can't shop or cook for themselves. We've been doing this for 32 years. We got started at the height of the AIDS pandemic, when people were alone and isolated and were starving. And some very, very courageous people decided that they had to go to other people's homes and make sure that they got fed. From that experience, we learned a lot about providing meals to people who were really, really sick. And so in 2001, we expanded our mission to serve people with all life-threatening illnesses. And today we serve people with an expanded array of diagnoses, from cancer to COPD to cardiovascular disease, end-stage renal disease, and hundreds more. We believe that food is love and that food is medicine. And the research and our 3 decades plus of experience really bear that out. So our clients, who are they? When our clients come to us, they are people who are the highest risk, highest need, highest cost people in the healthcare system. They're people who use the hospitals a lot, people who use emergency rooms a lot, people who really are living with severe and chronic illness. 90% of our clients live at or below the poverty level. 90% report more than one critical diagnosis. Many on top of that report 3 or more. About half of our clients report to us that they have behavioral health issues. And this whole combination of symptoms and diagnoses is what leads them to go to the hospital a lot, to count on emergency rooms and emergency departments, and really to be the small fraction of people who really cost the system the most. What our registered dietitian nutritionists do, and there are 7 of them, is they do medical nutrition therapy that includes a really extensive intake and assessment process, where they figure out what our clients really need to benefit from this individualized, medically tailored meal that only we provide. We're the only choice for these superutilizers, because these are the people whose health is really making it difficult for them to take care of themselves. So not only are they unable to shop or cook, they really don't benefit from the other meal programs in the city because they're too generalized for them and they need something very specific. So our registered dietitian nutritionists figure out what is that specific meal that best meets their medical situation. Medically tailored meals lower healthcare costs, promote better healthcare outcomes, and improve patient satisfaction. And we do all of those things. Largely the patient satisfactions, we help people stay at home where they're comfortable and more at peace. But from a cost perspective, you can feed someone for a half a year for the same average cost as 1 night in a hospital. So for every night we save somebody from going to the hospital, that's a half a year of medically tailored home delivered meals. That's pretty remarkable, I think. From an outcomes perspective, we know that what we're doing leads to better results. So I'll give you a couple of research examples. We did a study with colleagues from the Columbia University Mellon School of Public Health with people who were food insecure, who had horrible markers of both mental health and medical health functioning. They also were not compliant with their treatment. They didn't keep doctor's appointments. They didn't take their medications. And when they got access to the food that they needed, all of those markers turned around. They became compliant with their treatment and medications. They relied much less on the emergency department. They were hospitalized less often. A woman, 97 years old, was very much at high risk of going to a nursing home because she was really not doing well. And by bringing her medically tailored meals and having her talk with her nutritionist more about how to manage the meals along with her medications, she was able to stay in her home and not go to the nursing home, where again, she's happier, but also she's doing better. And then a man with HIV who's 58 years old, who also has a severe blood clotting disorder, was able to get stabilized and have continuous, good, healthy blood results stay in his home, and is now adherent to his medications, and is staying actively engaged in treatment. So the bottom line is, medically tailored home delivered meals save healthcare costs, improve healthcare outcomes, and lead to much happier and satisfied clients.
Just wanted to give you an example. So this is one of the ones from upstate, for example, and they're moving down that road. But did you hear how she was connecting everything to health outcomes in the end? So how many of you could take something like the cost of one day in a hospital and translate that to the cost of what you're doing? You know, and that's a pretty simple example. There's lots of ways to go down the healthcare road and start looking at, you know, how do you start moving those funds? I'm only spending a very small part of the bigger pot, and I'm actually saving money in the end. So you may be spending some money, but you're saving money when you think about it. And that's really the return on investment that the state is looking for. So when you look at it, so a couple other examples here. There was a housing project that really looked at a 40% reduction in inpatient stays. Think about the cost that goes behind that. 26% reduction in ED visits. You know, and these are all examples just to get you to start thinking about the outcomes that you might connect to. Nutrition, that's the one she just talked about. And then environment, reduces school absences, missed days, and work days. Think about it, child's off from school, mom or dad has to take off as well, or grandma, or whoever that support is, and that's lost money that's now not in the workforce. 66 to 70% reduction in asthma-related hospitalizations with home remediations. Think about it, asthma programs have advanced to the point where there is an asthma care plan, and I've worked with those kids for many years. It's really hard for a child to understand their medications. Sometimes even the parents have a hard time understanding it, because if I feel good, why do I need any medication? Yeah, if you learn a lot about asthma and helping somebody with asthma, there's a controller medication that I should take all the time in order to control that, even when I'm feeling good. And then there's a reliever for when I'm not feeling, you know, and your asthma starts kicking up. So to understand when I'm feeling good, I still need a medication is a very difficult concept. And you have to start to learn that overall, because when you learn, I feel sick, I take a medication, I feel better. And that's commonly where everybody comes from in that concept.
Can I ask a question or relate to the end?
You sure can.
Okay, so my question with asthma, we're talking about reducing asthma and medication. Does anyone talk about, is there anything in there that talks about asthma and nutrition? Because a lot of asthma can be linked directly to nutrition.
Mm-hmm.
Yeah, looking at nutrition as a separate subject, but a lot of asthma, sometimes it can be looked at, as nutrition. I'm just wondering, when they talk about the environment, I know a lot of it has to do with home, but then a lot of it also has to do with what you put in your system. So I'm just wondering if those two are ever linked together.
There's a lot of literature that already links that together, and you bring in a perfect question, because one of the things you want to think about is, as a small organization addressing a small population, should we start looking at bigger populations or partnering across with a lead organization to get into the game? It's one of the options you have when you start thinking about it. So maybe I do really good at addressing medications, but I know if I partner with somebody with food and start working on healthy nutrition with that same population, have we moved that outcome even further? Do we actually have a value proposition that's even higher?
Right, because food is tied in with diabetes, food is tied in with heart disease, food is tied in with asthma. So to me, it would make, and many other things, obesity, which ties into all of them. They all fall under that two or more comorbidities for many of these households. So there's just so much overlap when you put nutrition in there. It doesn't affect the housing as much, but in terms of the person's health and diabetes, which is out of control, obesity is out of control. There's some way of, maybe like you just said, doing more with nutrition.
Perfect. Absolutely perfect. So with that, we just talked a little bit about value proposition. And it's one of the things that many of you may be using or may not be using. It's a road that if you have not investigated, you want to start going down. So as an organization, what is my value? How do I start proving my value? Okay? And things that the state's already recognized that you should be starting to think about are things like what population you serve, what region are you looking at, what is your alignment within the value-based payment system. So how do you start aligning in those arrangements? Really looking at things, like you might want to start with something that's low upfront cost and then prove it and start building on that. Population size, can I handle it? What is my capacity as an organization? And really innovating. You want to start thinking about what makes us different than anybody else. So this is just a really simple set of steps for value proposition, just to get you start thinking about it. So you start thinking about what is your need, what is it that you already, what is your business plan, where are you? What is the need within the community that we're addressing? What is the solution behind that? So how am I going to start moving things? How is it different? How does it differentiate from what everybody else is doing? And finally, how am I going to prove it? You know, some of you may have access to some data and being able to do data. Some of you may be on paper trying to hand count things. You know, we're all at various levels, but in the end here, we're going to have to be able to prove where we're at. And contracting. I'm sure a lot of people are thinking, what do I have to do in the contracting? You really have a couple of options to think about. So we talked about how a managed care organization was going to be that lead that has the payment and has the responsibility. So you have the chance to talk to those managed care organizations and start aligning with them. So that's one way to think of contracting. The other thing is they're going to be helping the providers to outcomes. So there's also the fact that we could think about partnering with providers of care, and how do we start helping them? So if they're already looking to move their outcomes and improve them, how can I help them make sure that happens? Just some real simple things to get you start thinking about that. And the next one. If you want to get something about this. And I'm going to walk you through one more thing, and that's a value-based payment roadmap specifically to you guys, specifically to the community-based organization. You do have this in your handouts. And I'm just going to take you through step by step. A little bit of it will be repetitious because you've heard some of it, but I think it's important just to think of it as a step-by-step approach. So the first step, really thinking about it from a governance perspective. So New York State really has done a nice job to already position for us. They've already said, let's figure out what tier people are at, and let's make sure that those tier 1 organizations that have never been able to bill or be part of the Medicaid system has a foot in the door here. But think about it, it really connects to the social determinant of health and the work that we're all doing. Step 2 is looking at your stakeholder engagement. So one of the things you might want to think about is the size of your organization, what you can do, whether you need to start thinking about increasing that. Also looking at the provider groups that are out there and what they're providing. So what's the best partnership? What's going on? How do I start engaging? And that is something I know Michelle's going to talk about. I'm just going to say a little bit. And the fact that us as the PPS want to partner with you to start helping you identify. So if you're not sure who those partners are, maybe we can help do some of that investigation and start working down that road with you. Next is your business strategy. You all have a business strategy. How do I align it? Okay? Really start thinking about how your business strategy fits in to the bigger picture in the value-based payment system. Really understand where you fall in that roadmap and where those different partners and those different options occur. Step 4 is financially. I know that's the part we all need to think about because we all want to be sustainable. So as grant funding starts being removed, are we positioned to make sure that we can still survive? You know, what is it that we have that differentiates us from everybody else? How do we get there? This really, really is for the community-based organization, the way this was set up.
And how do we quantify what we offer the community? That's something you really want to think about. Because when you work as a granted organization, you're thinking about salaries. Here you need to think about how you sell what you do. So you want to kind of shift your focus from the persons who are doing the work to the services that you're providing in the community.
And step 5?
Can I actually talk, can we talk about finance a little more?
Sure.
Because I think a lot of people struggle with that. What is the value proposition? And I think what Rita said about thinking about salaries, a lot of these VBP programs seem to be like, where is the savings? And that's where the money is, right? Like, how can you reduce the costs to the healthcare system? It's almost like there's a disconnect, I think, sometimes for people to think about that. Like, where is this money coming from? How much risk can we take? How much savings is there to be had? What value do we really bring? And does that cover our whole operation? Or are we, starting from a baseline and then looking for shared savings and that sort of thing?
You bring up a really good point that I meant to say, I didn't, that I'll go back to. When you start looking at your contracting piece, as a Tier 1 CBO, you are not required to take on risk. There's nothing that says you are mandated as the CBO to be the one who's taking on the risk. Okay? While I say that, I wouldn't necessarily put that out of your head totally, because you might want to align yourself where you can get that base thing so you know you can pay your salaries and your overhead and all of that, but you might also want something in there. Can we start building something in there that gives me some of that upside risk? That if we help you make your outcome, can we share in some of that money on top of it, almost like an incentive? So, while there's nothing to say you have to take on risk, you just don't want to take it totally off the table, thinking about it.
Are there MCO guidelines that the state have provided for them in terms of negotiation with the CBOs? Or we're talking it's a free-for-all?
Well, they define where they gotta get.
Huh?
They define where they gotta go.
Restate the question also.
Ooh, okay.
Yeah.
So the question was, did the state actually define the steps for the managed care organization and how they contract, how they deal with this? What they've done is set the requirements. So they're setting the requirements that there has to be social determinants of health being addressed, and there has to be Tier 1 organizations brought into this whole entire process. And there's a whole bunch of stuff because there's outcome measures that they have to make. And part of those outcome measures is really shifting, like I said, 80% to level 2 or 3 for your provider, as well as all the health outcomes that they need to make. So and there's a list about, what is our list? 70, how long is our list for metrics?
54 quality metrics. But specifically to your question, the New York State is not being prescriptive around how a managed care organization should negotiate with a CBO.
Okay, so CBOs are essentially going to be left on their own to negotiate their own contracts. There are no government mandated rates or anything. Because,
not at this point. But you bring up a point, and we'll get into this later. How can what can Millennium do to support you as we move into this new era? And that may be one area that we'll right now make sure that we're addressing into the future.
There is some guidance for managed care organizations for the rates that they must provide certain services. In downstate, in New York City, and those rates are 15% less for upstate for a particular group of services. But managed care organizations remain free to negotiate contracts similar to the services that have been defined by the state, by the state, outside of those rates. And they can even offer those services on their own if they want to pay for them out of their own capitation that they get the counties that they negotiate with. So the answer is yes, there are some, but they're not, rates are not published for all of the services that can possibly be offered.
Mm-hmm. And it's something to start thinking about. How do I position myself for contracting? How, would several of us going together make us stronger? Or do I have enough on my own to do it? Those are all things you got to start thinking about.
So just another resource, there are lots of, and this is what they're called, value-based payment boot camps. And they are wonderful resources. So there's a couple of websites. So the OASIS website, the Office of Alcoholism and Substance Abuse Services, has links to get you to value-based boot camp. They have some webinars on their site. There is also a value-based boot camp in Rochester in November that Jason Helgerson will be at, and he is wonderful to listen to. The other website, which has just got a wealth of information, is the CTAC website. And again, that's got a boatload of stuff on value-based payments and boot camps and contracting. So there are lots of resources out there that can just enhance, because it is so much. And it's just a whole different way of thinking, what some of us have been doing for almost 40 years. Not me, no, yes, me.
No, you're absolutely right. And towards the end here, we have some links.
We do have links, but I want to stress, and we were going to stress this, that VBP boot camp that you just spoke about in Rochester is November 3rd. And sign up is now, and space is limited. And it's closing very quickly.
Yeah.
Yesterday, somebody called, and I think there were about 30 spots left as of yesterday. So if you're interested, I don't know if we have that specific link, but if you're interested in going to that in Rochester, I'd sign up ASAP.
And Jason Helgerson is great to listen to him speak. He is, it really is, should be invigorating.
And plus, I'll be there.
That's
Anyone wants the carpool, let me know.
Great.
So, and the step number 5 here really is starting to look at what data exists. What is the proof? How do I connect it back to healthcare? You know, think about how strong it was when she said that one hospital night saved pays for 6 months of those medically important meals. You know, so being able to come up with those type of things and being able to measure and show how we did it, and being able to say, you know, I have a population and we were able to save X number of hospital days, which added up to. Just some things to think about overall.
I have something to say on data, because I think this is really extra hard for like tier 1, tier 2 CBOs. I mean, we have health records, right, that and lots of data and a history of, you know, quality metrics that we're really working with. But, you know, how do you record what you do? And then what do you do with that data? You know what I mean? So at my organization, we have lots of community-based programs. And it's been a long road trying to evaluate the effectiveness, of, like the actual effectiveness, not like 10% of people were satisfied, you know, like what was the actual change in the community that happened because we did this. And we do have, like we've invested a lot in community-based program data collection. We have a special database and a company that, you know, created something for us. But I would love to talk to other CBOs who are interested in capturing that information and analyzing that information so that we could shoot ideas back and forth. I do think that, like I heard the diet issue, right? And I know we have teen pregnancy prevention that we do, right? Like what is the benefit of that to the system? What are the dollars saved when we do those things? And are the things that we're doing causing the change that's happening in the rates and for these patients? So I think we might have a way to figure that out.
You just talked about it in a partnership.
So
think about it. Could we get together to collect data?
Right.
And then help each other to be able to prove those value propositions.
But Chris, would you be willing to talk at this group about how you went about it for those interested in learning more about how to do that? So that's another.
I mean, I think that I'm getting close to something that is good, but it's certainly not the answer. And we're one organization, and the more people at the table talking, I think we could come up with something even better.
I was thinking when you were talking yourself into doing a workshop. So maybe we can get, maybe there's another person or something that can also add, we can add to that, training.
As long as it's entitled "A Round Table On," I'm good.
Not standing in front of a room, eh?
That's right, it's got a
And I'd love
multiple leg with
I'd love to
tables.
broaden that idea. Think about how much expertise we have in this room and how much we can learn from each other.
Chris, in terms of all our data goes to Cornell for the teen pregnancy prevention program. So would that be an avenue in terms of, you know what, you really need to give us back some of the outcomes of that data now?
We can get that back out of Cornell,
good enough.
but I think we need our own warehouse, right?
Right.
So many of you will recognize our next slide because some of you I stole it from will recognize. But it's so important to really think about. If you want to go fast, go alone. Doesn't mean you're going to get there, but you'll get there fast. But if you really want to go far and really fit in, really start thinking about how you go together overall. With that, I'm going to let Michelle talk a bit about what Millennium can do.
I only have 2 slides, it's really quick. So, as you see, Millennium is very well aware and attuned to this evolution of VBP in our Medicaid environment. So with that, we also have deliverables and milestones that we've mapped out around VBP. One of them, and it's VBP milestone number 5, just in case you were curious which milestone it is VBP support for implementation activities. So I won't read this, but it does talk about supporting structures and development and evolution of VBP arrangements within our Millennium 8 counties. And if you want to go on to the next one. And then milestone 6 is education and training plan. So we are building out an education and training plan. This is an example. You all actually asked for this type of an overview. We brought that to you, but we are looking at building out a larger training plan. We are working in collaboration with Community Partners of Western New York. We're bringing in an expert to build out a series of trainings and educational seminars that are going to be posted to our website and to our learning app called HW Apps. And one of our questions for you is, again, we gave a couple of examples, establishing a value proposition. We talked a little bit about that. Structuring, how to negotiate with the MCOs, and defining what your impact is using, where you're at from the social determinants of health perspective. So what we're looking for next, and we just have a little thinker slide, is feedback from you about specifically what you want. Now is the time. We're developing this education program. Now is the time. We don't want to assume that we know everything. We don't want to assume we know every organization out there. If you have ideas around what you as an organization could use as help as we go through this VBP evolution, we're looking for your feedback to make sure that we're providing you the support that you need. So, any input? Anybody on the phone, please speak up. You think we know?
I'd like a liaison.
Yes, hi, Michelle.
Hi.
I would like help in the legal aspect of the contract. Not just knowing where we fit in, but if Millennium could have maybe someone from their law department or legal department come and speak or do a presentation just of the verbiage or what have you, I think that would be very beneficial for at least me.
Okay, thanks, Denise. I'm sorry, I didn't hear your...
I was wondering if we could have a personal liaison, somebody assigned specifically to help BFMC, because part of my problem as I'm listening to this is that we offer such a broad range of services. Now I have to try to really align them, see where they fit. with this, and then prioritize which ones we're gonna lead off first. Because it's just not the mental health services and stuff, it's the rest of all the community work we do. You know, the mental health data stuff is a lot easier for us to get because we're mandated to collect a lot of that data. Or they've set it up so that they collect it from us. The other side of the community services, like the work we do with the seniors, etc., we're just starting to work on those kind of data pieces. So, and then, like I said, the youth services, a full range of youth services. So there's so many of them. I looked up there and I saw the true experience with the kids.
So what you're asking for, or what I'm hearing you say is you're looking for help to prioritize where that value is, and that's a great point. So, yeah, that's.
And I would echo that. I mean, the general trainings are great, but when I think about what I need like a personal trainer.
That makes sense.
Yeah.
So if there was a way to use the consultants and be able to, give the CBOs some time, some one-on-one guidance and technical assistance.
Okay, good.
Great idea.
Yeah. Okay.
I don't know, I just, when I was thinking about a real challenge for figuring out the value that you could bring for social determinants of health, I was thinking of your organization as being extremely challenged at that, right? Like, your organization came straight to my brain because you do so many things that I don't think that there's a money trail established. There isn't a data point out there that's going to tell you how your programs, that may be successful in reducing truancy, what does that save who?
Exactly.
And where do you go for that? Is it Medicaid, or is there a social impact bond with New York State education that needs to also happen, right? To make your organization in the spirit of what we're trying to accomplish, right? So I do think that personal trainer is a great
that's great.
Personal VBP coach.
We need to work your legs today.
Right. You can fit that in too.
A personal boardroom trainer?
Good. Anything else? Anybody else on the phone? Great. So our last slide does have links to the different, actually this is the boot camp next, actually I said November 3rd. It's, they call it Central New York, interestingly enough. It's in Rochester. This is an overview of the topics, and do we have another slide that shows the links?
The link's actually right to the side to get to it, so www.health.gov.
Right, yeah, that one.
Health.newyork.gov.
That's for the boot camp. And then the next slide is other links that are useful links for VBP, which ties into what Ellen was also mentioning. So there are a lot of resources out there. What we did recognize in our milestone document or our plan is that there are a lot of resources out there, and probably too many for one person to go through. So and it is overwhelming, and that's one of the other reasons why we're engaging with this expert to pull it all together and make it more comprehensive for you, where you can go to one source. So, but in the meantime, there are lots of different examples out there.
And
So
we send to everybody.
If you have not gotten the PowerPoint, we will be emailing them out. And with that, I would like to personally thank Ellen for hosting this today. And I will turn it back to Rachel to talk about next meeting and next meeting date.
Well, our next CBO task force meeting date will be January 18th, 2018. Already almost here. Who was ready for that? But we should also probably we will be in contact with you regarding our education series, as those will be coming out in the next few months as well. We just didn't want to give you dates and they, they're not be the actual date. So we want to make sure that you are aware that those soon will come out. That's all I have. Once again, thank you, Ellen.
Sure, anytime. We love hosting meetings here. easy parking, easy access. The construction out front is finally just about done. Certainly it's an available site for folks for meetings.
And thank you again to everyone who called in as well. As I said, please, if you could please, you knew that you were on your phone. I really appreciate that. And thank you.